Can I welcome you to the session? And I'm really, really conscious that, one, this is after lunch, and you're probably all having that after lunch feeling, but this is going to be an exciting session. Secondly, that there's been a bit of hype about this session all the way through. I think Thea started it with the heroic AI, and then we had Victoria Atkins speak about the funding opportunities for AI, and I think there's a lot of pressure on this session, but I'm not worried because I'm in the company of three amazing people. You're not worried. I'm not worried at all. So let me introduce Dr. Jess Morley, who's a postdoc at the Digital Ethics Center from Yale. She's come all this way to speak with us, and I'm looking forward to a very provocative discussion. To her left, we've got Simon Roberts, who is an anthropologist, and that feels absolutely right and proper because there's some really human and fundamental aspects of AI that we do need to explore together. He's also the founder of Stripe Partners. To his left, we've also got Sebire, who is a professor of Paediatric, Developmental Pathology at UCL, and he's also the Chief Research Information Officer. I decided your title was too long. I was going to abbreviate it, but we are today going to spend some time with you talking about the myths, the opportunities, the challenges of AI in healthcare, and I might just say health and care because we know it's all about the integration in totality. I do want to spend time talking about the fact that this is important, but we talk about AI as though it's homogeneous, so I'd quite like to get to a point of clarity. What are we talking about? What does it mean? I want to explore expectations because this is a timely conversation. It feels like it's tangible, given the political climate, given the permission that's been given, given the fact that it's ubiquitous in most other aspects of our lives. So why not in healthcare? There may be legitimate reasons for a safety-critical life and death system that I look forward to exploring together. And for me, whatever we do, it's about that equity lens. So how do we make sure we have equity by design? And I think Jess would tell us that the infosphere is a huge determinant of health. I can't sit before you without referencing my father when I were a lass, not so many years ago, you will all say. And when computers were new and disks were genuinely floppy, he said to me that data and knowledge would become really cheap. And it's our ability to mine it, to search it, that will really determine. And when we think about the AI winter and the fact that we came out of it, a lot of that was predetermined by the availability of data. Who owns that data? How do we maintain privacy? Those will be some of the interesting questions. But I'm going to start by inviting Jess to give us a 15-minute provocative discussion on AI.
Right. Hello, thank you everyone. Seeing as I am a digital native, I'm going to time myself on my phone and make sure we don't overrun. Okay, so this is going to be a really whistle-stop tour, and I hope we can then have a more in-depth discussion when we get to the Q&A. So I'm going to try and tell you what the rhetorical questions around AI are, as in how it is being framed in the way in which it's used by policy. I'm going to tell you why I think that's a bit problematic, why it's really hard to get it right, and then I'm going to tell you what I think we should be doing instead. I'm going to try and do that in 15 minutes. The last time I tried, it took me 92,000 words, so this is going to be a little bit of a challenge. So first of all, and I should point out, I made these slides several days before, so hopefully you will see that I am not making up this based on the conversations that we've had this morning. So policy has become incredibly focused on this idea of AI. It's become the savior of everything. If you read policy documents, if you read media, it's a bit like AI is going to solve death. We're going to be fine, no problems are going to exist ever again, and it's primarily because of these two ideas. So we can big datify health. We can use AI to throw at every single piece of data that we have, what people eat, how much they move, what their genetic record is, what their electronic health record is. Bring all of that together in order to make medicine more P4, so predictive, personalized, participatory, and preventative. And in the end, the aim goal is that we can achieve this theoretical nonsense triple aim of simultaneously improving population health, experience of care whilst reducing the per capita cost. So this is the ultimate ambition that's underlying a lot of the AI rhetoric that is currently circulating. The ultimate ambition being that you create this concept called a learning healthcare system. So this idea being that we have data that is collected in the patient care pathway. It is then circulated, it is sent to researchers to determine new causes of health, to make sure that health is more preventative, to make it more personalised. That gets sent back to clinicians in order to intervene with patients earlier. But it is also, bearing in mind how many conversations we've had this morning about metrics, fed back up to the system to tell people who is compliant and non-compliant with the current care pathways. It becomes a very, very quantitative, closed-loop system, and AI is sitting in the middle of that. So as you can see there, via the feedback loops, the NHS can learn how to most efficiently, produce the best outcomes and so become more efficient, more effective, and more sustainable. In case you don't believe me, this is from the NHS's draft AI strategy that came out in 2021. It was behind the login system, so not many people saw it. But it says, by 2030, the UK has a learning health and care system delivering better outcomes for the public, enabled by effective use of safe, ethical, and effective AI, and setting an example to the world. Now, I would like to point out that this is a deterministic statement. There is no how in there. It is only what. We're going to throw AI, and then we're going to get magic. But what is the bit that happens in the middle? Nobody really knows. So what do we mean by AI? You can get really, really confused by talking about different types of models. Are we talking about machine learning? Are we talking about neural language models? Are we talking about large language models? Are we talking about ChatGPT? It all becomes incredibly confused and technical. And what happens as a result of that is people perpetuate myths about what AI is and what it isn't. And it becomes extremely easy for people to get money and to drive hype by just saying that they're using AI. But if we're talking about what AI is in terms of a function, the idea is to better improve, basically make better clinical decision support software. So anybody who has ever interacted with the NHS will know that clinical decision support software is currently in use. It has been in use since around the 1980s. So if I, for example, go to my GP, it will flash up on the screen that I'm over 25 and therefore I should be invited to cervical screening. I then won't go, but that's a different conversation. And that is a rudimentary form of clinical decision support. What we are trying to do is to provide clinicians with the right information at the right time, in the right format, through the right channel to reduce the amount of uncertainty. So if clinicians are trying to predict what's going to happen to this patient, they have a huge amount of uncertainty. There's uncertainty about the patient. How is their genetics interacting? What about their phenotype or their genotype? How do they eat? How does that change their life? There's also a huge amount of uncertainty with regards to whether or not the treatment is going to be effective. So the idea is if we can intervene in AI using all of these different models and present it at the point of care, we've reduced the level of uncertainty and therefore we have hopefully made things more effective. But we're specifically talking about algorithmic clinical decision support software rather than basic clinical decision support software. You don't have to read all of these words. They're there for people who get nerdy and want to read it later. But the idea is that what we're moving from is from a presentational system to an inferential system. So from I'm going to present to you as a computer the information that you already have, and I'm going to show it up. Jess is a female, she's over 25, to Jess is a female who is like X number of patients who sit in this box. Those types of patients were most responsive to these types of treatments and they were most exposed to these types of risk. It's all relative risk. It's not absolute risk. That's really important. And then you have a reasoning center in the middle. This is where the algorithm sits. So if anybody is ever hearing the word algorithm, that's where it sits. It sits in that reasoning center to say patients like A match patient like B, therefore we should treat patient B like patient A. So the point of me highlighting that is that as much as we have, I've just said, sort of positioned this as being about personalized medicine, what it actually is about group stratification. It's like targeted advertising for medicine. So the NHS has also got a doomed history, right? The NHS does not do well at large-scale transformation. There are pockets of the NHS that do digital really, really, really well, fantastically well. Neil is a classic example of some of the work that's happening in gosh, it's amazing. But these are pockets. Large-scale, top-down transformation has typically gone very, very badly in the NHS. We've had programs like Care.Data, we've had the National Programme for IT, which slightly, I'm sorry, predates me, but I know it was a big thing. We had Streams and the Royal Free. So the question is, how can we help NHS make use of AI if it has this track record of being poor? And what does success look like? Well, success means we have to implement AI in a way that is technically feasible, socially acceptable, ethically justifiable, and legally compliant. It must be all of these things at once. The issue is that most of policy currently deals with these things in silos. So you'll have one person over there talking about technical infrastructure. You may have another person over here talking about data policy. You then have the NHS, what was the NHS AI lab, but they have the AI ethics team. They talk about ethics. And then there are occasionally some people, normally in comms, who go and say, hey, we should have a conversation with patients. But those things don't join up, whereas actually one influences the other. They are cumulative. It's really, 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 really hard to get AI right because of a number of complicating factors. It's a bit like saying we want to run HS2 on a rotting wooden railway track. So we have to try and predict all conditions all the time at once for every single individual patient. The technology has to be run on top of legacy clinical systems, and it has to integrate with them. Anybody who has ever been in an NHS hospital, you've heard people talk about it this morning. They don't have a charger. There's one computer on wheels that's shared between four wards, and they don't have a working keyboard, and then this person over here doesn't have this. And then we want to run AI on top of that, really, without having invested in that as well. It also brings new accuracy and privacy risks that we haven't had to deal with before. Then we have to think about what is the value proposition. So this is the big surprise. There is currently extremely little evidence that any of this stuff works in practice. There is brilliant evidence that it works well in a research lab where really annoying people like me sit in Yale University and go, I've got a supercomputer, I can run an algorithm, and then I'm going to publish a paper and it's going to have the best statistical accuracy in the whole world, and I'm going to feel really clever. That is not the same as clinical efficacy. And that jump does not happen. If we look at the number of clinical trials running that is using AI, it's almost nothing. So to give you just a couple of figures, the FDA in the US has approved 692 software as a medical device using AI and ML. The total number of clinical trials using AI and ML is 336. 80% of those have not reported any results, even though they completed more than a year ago. There's a huge amounts of spin. The whole problem, the whole system is just extremely broken. We have problems with clinical workflows. So we've heard already this morning, we heard the example of breast cancer screening being used as an example of how amazing AI is going to be. AI, I do not take umbrage with the claim that AI can read breast cancer scans. Of course it can. AI is fantastic at recognizing images. Anybody who's ever had to prove they are a human by training an algorithm has seen that AI does image recognition extremely well. The problem is, if we speed up the diagnosis pathway, so we throw AI at the front end of the clinical pathway and we diagnose thousands of people all at once, we have not improved the system's capacity to actually treat them. So what we have in fact done is given people a really threatening, really psychologically harmful theory that they think they are at risk of cancer, and then not given them access to treatment. That is harmful. It is ethically harmful. So we have to think about that as well. There's the external context. The regulatory system, we can hopefully talk about this more in the Q&A, is broken. We don't have sufficient medical device regulations. Data protection regulation doesn't really work well for this. How do we deal with liability? What about discrimination law? What about consumer protection law? All open questions at the moment. And then there's adaptation over time. These machines, they learn in real time. So to give you a classic example, the reason if we are talking about clinical decision support, it is running across a service in real time. It is learning how to predict better. It is then feeding that information back to a system that is doing simultaneously research, direct care, and service analytics. The law interprets those three things as being separate, but it is not. It is doing all three things at once. And then we have to think about, we're careful what we're doing. So very often we try and think about AI, and what you see of these types of narratives is that it's just a digitalization, it's just a thing, it's just a tech, it's just taking electronic health records and making them digital. But we don't think about the actual bigger transformations that are happening. And if we don't, there is a real risk that we fundamentally undermine the values that the NHS prides itself on. If we rely too heavily on AI, we will displace the patient from the center of care. So who is right about what they feel in their body? Is it the patient or is it the algorithm? Because they're not the same thing. We are taking care away from being physically embodied in a patient and being all about the digital self. The digital self does not necessarily match the physical self. So who is right? If I go to my clinician and I say, I don't feel very well, but the clinician says, yeah, but the algorithm says you're fine, what do we do in that situation? We are disrupting the fundamentals of care because we are changing the power dynamics of the system. We are introducing new partners who come from outside of healthcare, who have different skills, who don't have the knowledge and the contextual and understanding of the healthcare system, and we are giving them huge amounts of power. So everybody might have heard about the FDP. I don't have a problem from the FDP from a privacy perspective. Privacy is a technical thing that you can solve. What we are doing, though, is transferring the power and the knowledge and the understanding of the NHS's data to a third-party private company. That is a problem if we are not retaining that knowledge inside the NHS. And then we have the biggest one, the most important one, is that the NHS ceases to be for all. This is what Nnenna was talking about in terms of equity. Algorithms do not work well for everyone because the current healthcare system does not work well for everyone. What you often hear is, oh, AI is going to be more objective. It will be better at humans. It won't be biased, but it's trained on all of the biased data that were produced by humans. How do you think it's not going to be biased? It's also going to introduce new forms of bias in the ways that we don't currently know about. And in particular, it's creating this thing that I call the inverse data quality law. So most people in this room will know of the inverse care law. The inverse data quality law is essentially we're going to generate really high quality data on people like me who walk around. I'm pretty fit, I'm pretty healthy, I use Strava all the time, I have an Apple Watch when I feel like it, I will use MyFitnessPal to track how much I eat. Fantastic, my data quality is going to be absolutely brilliant. The thing is, I don't need the healthcare system. People who do need the healthcare system are not going to have the same level of data quality. So this is just a tiny picture. Don't worry about it too much, but it's essentially saying that we have to think about hundreds of different things to get the ultimate end game. So even if we're just talking about meaningful accountability, so who do we hold accountable when things go wrong? We have to think about the information governance, we have to think about medical device law, we've got to think about clinician and patient protection, we've got to think about auditability. If we're talking about epistemic certainty, so do we know that the information is reliable, we've got to think about data quality, data quantity, and data interpretability. Policy coverage is not great. Policy tends to at the moment, massively underestimate the complexity of this type of thing. So for example, if we just look at information, it doesn't really touch on data interpretability. It tends to think of data quality as being a very narrow problem. The reason that I think data policy is currently insufficient in this area is because of that top left-hand corner, where it's saying second-order change versus first-order change. I think policymakers currently think that all we're doing is taking a paper system and making it digital. We are not. We are fundamentally changing the core operation of the healthcare system. That is a different thing, and therefore it requires a different level of thinking. And so ultimately, I asked a whole bunch of patients, a whole bunch of clinicians, a whole bunch of system managers, like well over 90 people I interviewed on this topic, and I asked them, what would you want to happen? They gave me these answers, and then I came up with this. So instead of trying to throw AI at absolutely everything, remember what I said about it solving death, that is an information want. That is assuming that we always want more information all of the time. I don't think we do. I think that is problematic. I think we should instead focus on information needs. That's my time. We should focus on information needs, which is when we know that there is a specific gap. We have evidence that if that specific gap is filled, it will lead to better outcomes. So what we should do is focus on using AI to maximize the utility, usability, efficacy, and trustworthiness of existing NHS information for the purpose of meeting clearly identifiable information needs. And those needs need to come from the front line of the NHS rather than from tech companies who go in and think the NHS has data, therefore I can build a cool algorithm. And that's it.
So, I don't know about you, but I was looking forward to cognitive acrobatics. I think I got them in full. And I think we all came into the room thinking AI, this panacea, and actually what we're hearing really are some of the problems and the practical elements that we need to genuinely consider intentionally if this is to help rather than hinder. So my question, and I would like to bring both Simon and Neil in to think about, based on that skeptical view of AI, is there a how, when, where, when? I said that twice. How, where, when, how, and with whom? we would need to move forward from an AI perspective in terms of health and care. Can I start with you, Simon?
Yes, you can start with me. I mean, I don't want to, well, I am going to join the kind of rain on the parade panel because I think a sort of a note of skepticism is probably called for. And yeah, having worked in and around technology, despite being a sort of an anthropologist, I'm a massive adherent to Amara's law, which is we tend to overestimate the impact of technology in the short term and underestimate its impact in the long term. But at the moment, we're in the short-term phase. And having worked at Intel with a load of microprocessor engineers who were all adherents to Moore's law, I always used to say to them, there's no Moore's law for culture. It is much more uncertain and, if you will, non-linear than some of the laws of fundamental sort of physics and engineering. So I think at the moment, there's sort of, I want to sort of say three things as quickly, not quite as quickly as Jess covered her entire PhD, well done, is, you know, first, I do think it is beholden on all of us to kick the tires, if you will, on many of the claims being made about AI, and you did a great job of that. And I think that's important because there's a strategic vagueness, if you will, to the word AI at the moment, because it seems to me that those who use those words, and often they're tech bros and technologists and venture capitalists, and often they're politicians too, we've discovered, there's a sort of strategic vagueness, which means that those of us that don't know exactly what they're talking about assume that they know what they're talking about. And I suspect that often they don't. Right, and so there's the sort of suggestive power of AI gets kind of blown up and amplified. But in reality, I think we're living in an era in which there's a lot of fake it to make it going on, right? And the nicest example of this for me is the autonomous taxi company Cruise that operates on the West Coast, who have 1.5 remote assistance support people for every taxi that they operate. So which part of this system is autonomous when you've got a vehicle that can kind of drive on its own, but 1.5 people that are actually driving it unseen? It's what some authors have talked about as ghost work, right, in the technology space. So often there's a huge amount of humans in the loop. So I think we need to, and Tesla's another good example. So if you excuse the pun, I think, with their fully self-driving, well, it's not regulated as such, and it's extremely dangerous to have people on the road thinking that it is fully self-driving. So if you pardon the pun, I think we do need to kind of continually kick the tires on some of these claims, right? And I think that's never going to be more important than the healthcare space. So there's a nice sort of framework that was brought out, I think, by the Department of Defense or NASA in the sort of 70s called technology readiness levels. And I think we seriously need to kind of think about what that looks like. The second sort of point is just a simple one around framing. I think a lot of the ways that we frame this technology we should pay attention to, because we tend to anthropomorphize, we tend to talk about AI in terms of oracles, as sort of all-knowing heroes, to use Thea's words, and that's problematic. And I really like the framing of a psychologist called Alison Gopnik, who talks instead about AIs as cultural technologies. In other words, they're actually not that, or technologies of kind of cultural transmission. So they're not actually that different from libraries or alphabets or the internet, right? They enable us to build on the knowledge of previous generations and to communicate that amongst ourselves. So rather than think of things as smart, like the British Library is not smart. Yes, it contains lots of intelligence, but it's not smart. And AI is not smart for the same reasons, right? It knows a lot, and it can be useful, but it's not in itself intelligent. And then the final point, I think, is the thing that worries me most is a conversation about, like, what's AI actually for, right? Can we talk about that? And you've done a very nice job, I think, today in opening that up. But I'm really beholden to and the economist Eric Brynjolfsson's sort of framing, where he urges us to draw attention to the difference between augmentation and augmentation and automation. And I think the standard thing that sort of economists or business people and often government ministers do when a new technology has come along is say, the low-hanging fruit is automate. Let's just take humans out of the loop. Let's not impact what we're doing and just change sort of the how of that, right? And I think augmentations are much more interesting place for us to look at because it's about the complementarity of human and machine, right? And it's about thinking about what humans can do that that machines find very difficult. Comforting a patient would be one slightly obvious thing, right? And then thinking about what machines find very easy that we find quite difficult to do or find quite difficult to do at pace. And I think Brynjolfsson's argument is that the set of tasks that humans and machines can do together is much, much bigger, much more interesting, and ultimately going to be much more productive for us as a species than thinking about the things that we can have machines do for us that we no longer want to do. There are clearly some things we don't want to do, and AI is going to be able to do those. But in large part, I think we need to reframe this about complementarity rather than substitution.
So I'm really loving that, but I'm going to take Chair's prerogative and ask one little question before I move on to Neil. So there's a real opportunity, and we had productivity as one of the key elements of the discussion today. We speak about augmentation. We speak about support. But many people would argue that there is a risk of substitution, particularly for the workforce that is less skilled. Whereas for the workforce that is more skilled and more paid, they may be able to operate at top of their license. Is there a concern, and how do we mitigate that up front? And Neil, just to put you on notice, I'd like to hear about the application in the NHS at the minute, because it is here, isn't it? Simon?
Yeah, so I mean, your question is essentially one about, are there some people, as it were, in the economic stack that are going to be able to access this or avail of it, and others that aren't? And I think the simple answer to that is yes. I was talking to somebody at lunchtime about in terms of sort of workforce and well-being. I mean, the obvious thing post-COVID that strikes me is that people who have jobs that require them to be present somewhere 5 days or more a week are seriously disadvantaged compared with, you know, the carpet dwellers like myself that can pick and choose where and when they go to work. And I think some data shows that actually many people would prefer to be paid less to have the flexibility. So I think there's a kind of an analog there. I'm not answering the question very directly, but I think the simple answer is yes, and that's going to become problematic in the workforce in the future in the same way that post-COVID working relations have become so.
And there's an imperative about now. Neil, I wonder if you can share some examples, because you are live in the NHS space, and no matter how concerned we are about AI and what it might mean, it is present, it is pervasive, it is here. Over to you.
Yeah, thanks very much. So just to give a bit of a précis before I start, that I'm actually a big fan of what AI could potentially do, but you might not think so after you've heard what I'm going to say, because this is really based on some experience. So essentially, I'm a clinician, a clinical academic. I run our clinical informatics research program, and we've set up a kind of embryonic clinical intelligence unit to really see how do you practically get this into an NHS organisation, as opposed to a single tool working for a radiologist, for example. And just want to mention really a few of the learnings, lots of which really build on what you mentioned, Jess. So the first thing is there are some really fundamental things that need sorting out before we start getting too excited with AI and what it can do. The first is around NHS infrastructure. Now, my background and experience is from a tertiary hospital, but actually the principles are exactly the same for primary care, social care, any health care or health and care organisation, really. First is the infrastructure, and I don't mean an electronic patient record infrastructure, although many hospitals still have at least some paper, so forget AI at scale until that's sorted out. But the infrastructure meaning, what is the infrastructure in your organisation for taking that data out of your systems, managing it, engineering it, scalable compute, etc. So a cloud infrastructure that is designed for this purpose. almost no NHS organisation has that. Second thing is the governance. Whose job is this? This is not something you give to an ICT department like installing Word and then leave it alone. This needs a whole structure of how the organisation is going to decide what they are going to use this for and who's going to be responsible and how those decisions are going to be made. The fundamental thing is then around the data engineering. Because everyone says, oh, NHS data is worth how many billion, depending on who you choose. It's worth nothing in the form that it's in at the moment. It's only worth something when it's in the right format. It's only worth something from an ML or AI perspective when it's in the right format for ML or AI, which needs a huge amount of data engineering. You have to take the data and do stuff with it to make it ready for whatever your secondary use is. Who will do that? Because that's a very skilled role that needs technical skills and knowledge of the domain. You can't just bring someone in from Google or wherever if they don't know about healthcare, because you need the domain knowledge. What are the resources for this? Which department is going to do this in an NHS hospital? Then in terms of the sort of tools itself, whose job is it going to be to run the tool? That, exactly as you mentioned, this is not something you just install. You need to know how this is working, whatever this tool is, and who's going to make a decision in the organisation as to whether that tool is working well enough. So to just give you a made-up example, you buy an AI tool that is supposed to predict something, doesn't matter what it is for now, and with an accuracy of 80%. And let's not get into what accuracy is, but an accuracy of 80% for now. And someone checks it, and they run it, and they go, great, it's working. Tomorrow you run it, and it's 79% accurate. Is that okay? What about the next day, it's 62% accurate? What about 23% accurate? The point is, somebody's job is to do that, and then somebody else's job is to go, hold on, is that good enough? And how, in general, would you, as an exec member, decide whether a tool is good enough to use? Because your doctors get the diagnosis wrong. Absolutely, every study shows doctors get the diagnosis wrong at least a third of the time in the first diagnosis. So if we have an AI tool that gets it right a little bit better, is that okay? How good does the thing have to be for us to say, well, it's better than Dr. Smith, so actually it's okay? But lots of studies show that patients don't accept that. They will accept a doctor doing a tragically bad job because they're very busy and they're human, but they won't accept an AI system that gets it wrong hardly at all because it's a nasty robot. And so there's a really interesting thing about the trust, which we might get on. And then I guess the last part then is really around what do you do now? What's the role in this context of industry and other partners? So what is going to be the relationship? Because if the NHS is going to run, people talking about LLMs and ChatGPT, everyone is sort of doing something with large language models. What's the NHS policy on large language models? What's your organisation's policy on large language models? What can you use it for? What can't you use it for? Which data can be put in? Where are you going to run it? Who's going to do the compute? These are not minutiae of individual things. These are strategy-level decisions which are currently not being made, or they're being made individually in multiple trusts. And just then to finish, you asked me about things that are there now and the impact. So my day job, so to speak, I'm a diagnostic pathologist. I specialise in tumours and renal biopsies. I basically look at a squashed piece of tissue, I look at it and I go, I've seen that before, that is this type of tumour. It's the same as showing you a picture of a cat, and you can recognise it's a cat, but I can recognise exactly what type of cat it is. That's what pathologists and radiologists do. There is no possible way we should still be employed to do that role in the future, because machines have to be able to do it better. But at the moment, we have pockets of individual tasks that they can do, but we don't have a structure as to how to do that, and we don't have a plan for how we're going to train the machine to do that, and when are we going to be ready to say, I don't need you anymore. because this thing is better.
Goodness gracious me, there's a lot in that. So there's something about predictability. I would name the cat, by the way. There's something about the predictability and the ability for systems to do better than humans, but the social acceptability of failure if it is automated versus human. Should we be telling patients that we are using the automation or the AI in the ways that we are? There's a whole different infrastructure of conversation, strategy, and social and ethical discussion that is needed. There are a lot of questions, and I don't want to hog the stage. I do want to ask very quickly one question of each of you before I open it up to the audience. We've spoken a lot about the problems. I'd like to imagine 5 years from now that we were able to be successful with AI in health and care. And maybe just in 30 seconds each, if you can tell me the potential areas in which you could see AI being successful in health and care. I'll start with yourself, Neil.
So for me, everything to do with diagnostics that a human does now will be better done by an AI system. So anything that involves a human looking at a picture of something and saying, what is this picture of? That will be better. Anything that involves a human listening, I cannot possibly believe I can hold my phone up and have now for years in the lobby here, and Shazam will tell me which song it is, who wrote it, which year, and yet I can't do that for heart sounds. Heart sounds are super easy, and chest sounds, but we haven't taught systems. So anything that involves like ECGs, EEG, anything that is a reproducible type of pattern, and you're just saying what type of pattern is this, that absolutely will be changed. But the fundamental problem then is, as Jess mentioned, you've just shortened one bit and made it better, but so what now? And one of the main things I think that we were a bit shocked at, and
I'm going to hold you to your 30 seconds, but you just keep going.
Sorry, I'll be quiet after this. But honestly, one of the really important things that I think we don't do enough of is with an AI system saying, what if it worked?
Yes.
Before we even start, because if you wouldn't be able to deal with the thing that it does, even if it works, don't bother doing it.
What must be true? Absolutely. So I heard recognition, repetition. Absolutely. Thank you very much. What about yourself?
So +1 to all of that.
30 seconds. You see if you can beat it, yeah?
We did some work with Google long before AI was a sort of household word that everybody talked about over breakfast every morning. And the thing that we discovered was that we looked at how they would introduce it into G Suite and tools like that. The thing that people wanted it to do was the donkey work. Do my expenses, do my meetings, do my rostering, etc., etc. My view, apart from the stuff that I can't speak to because I'm not knowledgeable enough, is that to build trust, actually get AI to do some of this stuff, like make life better at the coalface, take difficult but boring tasks away from people, free them up to do the care, to do the comforting, to write the care plans, the stuff that is human and embodied and is at the heart of relational systems, and let the other stuff go.
Thank you. So drudgery, transaction, whilst we maintain relations. Jess?
30 seconds?
30, yeah, I want you to be the one person to achieve 30 seconds today. Go for it.
I'm going to do it. Make better use of unstructured data. So unlock the capability in free text. That's what AI can do.
Goodness, thank you. And I can think of lots of examples of free text. The staff survey has just come out today, all our different bits of feedback from complaints. Great opportunity, thank you. I want to ask one other person that question, if that's all right. So ChatGPT, if you're in the room, in 30 seconds, please, can you tell us what, in 5 years' time, you would see as potential success in our health and care? In 5 years, the most crucial area where AI can significantly enhance NHS is personalized medicine through advanced diagnostics and treatment optimization. AI-driven tools can analyze patient data, tailor treatments, predict disease progression, and optimize medication regimens, leading to more effective and efficient healthcare delivery, goodness gracious me, while minimizing adverse effects and unnecessary interventions. This could revolutionize patient care by ensuring treatments are precisely tailored to individual needs, ultimately improving outcomes and reducing healthcare. All right, I don't know if I get you to vote in terms of who gave the best answer there. ChatGPT stuck.
I think he's drunk his own Kool-Aid, assuming it's a he.
And you assumed that it was a he. I would just let that slide.
No,
all right.
I did correct myself on that.
Thank you. So there are lots of questions I can ask, but I really wanted to involve the room in what has been a provocative conversation about we're not quite ready, but this is a moment in time, and what must we be doing now to get us ready for the potential benefits. Kevin, I didn't even say hands up and your hand is up. Over to you. I don't know if someone can take a mic. If you can say who you are and ask your question.
Thank you. Great session. Oh, I have to stand up. There's a broad assumption that AI is going to make everything better and cheaper. Is it not possible that it doesn't make things much cheaper? And you talked about the inverse data law. Is there not also the digital iceberg law, where you turn it loose on natural language and it uncovers a whole bunch of stuff that we've missed that we then need to chase up? Is that not possible, that it screens out a load of disease that we haven't seen before?
Jess?
Yes. Is the short answer. Yes, that's ultimately the risk, and that's one of the reasons why one of the things that I've tried to push before is that we should subject these types of things to the same tests that we do when we do national screening tests. Right? When we introduced our national screening program, we think about, is there health economic value to this? Is there benefit to telling the patient about this risk, or is there actually no benefit at all? Is it going to cause more harm than good to either the patient or to the healthcare system as itself? For some bizarre reason, when it comes to risk stratification tools, which are doing the exact same thing, they're just doing it in an algorithm without having seen the patient, we don't subject them to the same test, and I think we should. Otherwise, you get those exact problems.
Thank you. Lovely. Any other questions in the room? Naomi?
Thanks so much. Naomi Lee from NICE. Huge thanks to Jess and the panel, because I understood that you're experts in this area, but also really a lot of healthy skepticism. I think the question that really stood out for me is, we're all describing the potential of AI, but you described to us the kind of lack of evaluation, to give one example. Now, Jess and I know each other because I have authored one of so many frameworks for the evaluation of AI on behalf of the World Health Organization, ITU. It's not that these things don't exist, right? But there's something in our incentive structures, as Jess just described, that allows us to kind of continue proliferation without the adequate evaluation. I picked that one area because it's close to my heart. So I wondered if I could ask the panel, what are the kind of guardrails and incentive structures that you would change to get from where we are now with your kind of expertise and skepticism to that kind of future world that you described?
Thank you. Something about the training wheels we need to put on now whilst we build for a better future. Who'd like to start on? Neil, you look very pensive.
Yeah, I'm just thinking, I'm not sure that in terms of the specific kind of training wheels part, but in terms of the incentives, I think that is a super important area, and it's an area that I think has been fudged quite a lot in other things before, but now AI is coming. We can't avoid it in the same way, and that is around in terms of who is going to get the benefit from this tool. So let's say you develop a tool that is very good at predicting something, and you can, I don't know, monitor patients at home so they now don't have an admission, let's say, a really simple example. The hospital would get the money if they did have an admission, but if they didn't have an admission somewhere else, someone else saves the money. I know that's a very simplistic kind of concept, but if you imagine now that we had AI tools that could help that process and could help patients be managed at home or not be admitted, etc., then the general models that we have at the moment around who's going to pay for this thing then and whose job is it to run it depending on who gets the benefit, I think are going to be even more complex than they are now. I don't know what the solution to that is, but it's another area that I think absolutely is going to have much more focus on it with the AI and digital tools that are much more portable.
Indeed, when we talk about productivity, there's a real question about who lands the benefits and how do we make sure that the people are putting in the effort and the benefits are married, or that we stop talking about which pocket and we start talking about the totality of a budget in a different way with the patient at the centre.
Hi, Anita Charles from the Health Foundation. I'm a health economist, so I'm going to talk about money. So obviously, as we discussed this morning, the Chancellor announced £3.4 billion to kind of go into this area starting in 2025. So my question to the panel is, with that £3.4 billion on the table, if we're going to get the NHS into a position where this is maybe taking longer, a good news story rather than a problematic repeat of some of our earlier forays into tech, what would you spend the £3.4 billion on?
Gosh, lots of money to spend, indeed. Can I ask for 3 things from each of you? And then I think Steve is also volunteering to answer. He probably has a list already sorted out. 3 things from each of you. 3.4 billion.
Well, I made an X thread exactly on this morning, but the 3 things that I would say in this particular context focus on creating algorithm-ready data sets. So we already heard from Neil that we have a bit of a problematic myth that the NHS data is this gold mine that's just ready there as leprechauns can find at the end of the rainbow. That is not true. We need to curate it. We need to target it. We need to deal with missingness. We need to deal with gaps. So create algorithm-ready data sets, focus on electronic health records. We only ever talk about electronic health records as whether or not they are available, and they are not universally available in the NHS, but we don't talk enough about the fact that they're not standardized, they're not interoperable, we don't involve human-computer interaction designers in them, we don't have APIs that sit on top of them that make them available, and we don't have data portability rules, which we need in the law. And then the third thing is I would focus on making the infrastructure better for making the opt-out more nuanced and involve dynamic consent.
Thank you. Lovely. And I'm going to come back and summarise these in a minute. I'm just going to come to...
I'm only going to give you one thing.
That's all right.
Which, as somebody that sort of devoted most of his career to sort of trying to help technology companies build stuff, not only that sort of works, but people love or like, that is nuanced enough, you know, that takes account of the environments in which it's operating, you certainly wouldn't need to spend 3.4 billion. You'd have some stuff left over for charging cables and other things that we talked about this morning. But I do think kind of taking seriously Thea's injunction to try to really understand the context in which you're trying to land this, rather than just doing it to people, because it just seems to me that technology companies and policymakers and others spend a lot of time doing things to people with technology, and it's a slightly vague answer, but I do think it's genuinely important.
So I heard the why being the most important thing.
Well, why and then how? Like, let's get a really in-depth understanding of workflows, of the therapeutic encounter, of how we're going to diagnose more quickly but make improvements elsewhere in the system, so that we can actually get people through it, if that's the promise. So yeah, just, you know, the human factor. Let's not run away with the technologist fantasy. There are enough Elon Musk in the world as it is.
Right, moving swiftly onwards.
Yeah, biggest bang for the buck by far is forget the AI, focus on the data. So the infrastructure, the core infrastructure, the data engineering, and for goodness sake, let's digitize everything. Because while we're still doing things in an analog way, whether that's an ECG or a sound or a pathology slide, if it's not digitized, we can't use it in the future, we can't learn from it. So unequivocally, those 3.
Lovely. I'm really hearing the focus on EPRs, not just being EPRs in and of themselves, but actually the entry point into the EPR. How do we actually hardwire the things we put in so we have complete data sets? Would be one element I want to just not lose. Steve?
Steve Powers, National Medical Director, NHS England. So I certainly didn't come into the room thinking that AI is a panacea for everything. And if anybody thinks the senior leadership at NHS England or the board at NHS England think it's a panacea for everything, I can assure you we don't. But we do think it will have its place. And we do think it has its place, as the panel has described, by putting it into clinical pathways, not just clinical pathways, as part of a clinical pathway design, and not just something that gets dropped in with the, you know, the hope that it will solve things. And when it's done in that way, then it does have benefit. So on speed of diagnosis, Juliet Bouverie for the round table, sorry Juliet, talked about mechanical thrombectomy. We're not where we need to be in this country on mechanical thrombectomy.
Part of that is around speed of diagnosis. The quicker we can diagnose patients who will be suitable for thrombectomy, the easier it is to keep the ambulance crew who've taken them to be able to then transfer them to the thrombectomy site. But if the ambulance crew has to wait around for an hour or two without diagnostics are made with busy clinicians, then that's not going to happen. But you do have to design the rest of the pathway. So you do have to ensure that you then have the ambulance pathway in place. If the AI, which is currently deployed in stroke pathways to aid faster diagnosis, aid clinicians, still needs a clinician. So it does require the redesign of the whole pathway, and it does require that human interaction as well. But put in place properly with appropriate evaluation and oversight, I think it will generate better patient care, and it will increase productivity as well. But everybody's right. In itself, it's not a panacea. It is an enabler.
And that's a key term. So considered implementation, and just to not lose the AI-generated need, which is both time and volume bound. There was a hand at the back of the room that was very patient, who's just standing up. And then I can see Bola next after that, and then you're good stuff.
Thank you. It's Jennifer Dixon. I'm the Chief Executive of the Health Foundation. It strikes me we've, an interesting panel, thank you so much. It strikes me we've had the Gartner's hype cycle on full display here this afternoon, from the technology trigger to the peak of inflated expectations to the trough of disillusionment, to the slope of enlightenment and the plateau of productivity, which may take some years to achieve. So I guess my question then is, this is the world we are going to live in. Other industries will be using this. We have a room full of leaders here. How best do they lead, given that hype cycle, given the possible resistance and the yes buts that will be everywhere and then yets everywhere in the system? How best do we lead the service and patients and staff to realize the benefits here? What should leaders be saying? What should their zeitgeist for this be to lead the staff and patients into the future where we want to be? Thank you.
Really, really helpful question. I'm going to take the question from Bola, and then I'll come to the panel with both. Bola.
Thank you. Bola Olabi, NHS England. Given that both predictive and generative AI at the moment depend on machine learning, and most of those algorithms are being taught on predominantly 96% European data sets, what mitigations do healthcare systems need to build in so that research, policy, and financial decisions are not continually biased in the way that you were talking about, Jess?
Perfect, thank you. So I'm going to start off with, we're all going to leave this room as health leaders able to effect change. What is the conversation we need to be starting now? What are the things we need to be doing now? And in that context, what of that will reduce the amplification of inequality in the way Bola has just described? Jess?
Sure. So the first thing in terms of being leaders, I think there are some things that might sound trite, but I don't actually think they are. One is to be skeptically optimistic. So I think we have to say these things can work, but it's not going to work automatically. And so therefore, what are the questions that I have to ask? If I am a person in the room, I am a senior leader, I am a policymaker, or I am the person in my hospital, I'm the CCIO, and I'm being approached by a tech bro and they've got a really shiny tech slide, then what are the serious questions that I need to ask them? And those questions can be very basic, but they're very effective. Does it work? And to this point, who does it work for? How did you demonstrate that? Where can I see the evidence of the efficacy? Just asking those kind of questions. The second thing I would say is really not fall foul of AI exceptionalism. So I think there is a little bit of a problem where we have you know the nursery rhyme, sticks and stones may break my bones, but words will never harm me. I think there is a little bit of that influencing the way in which we are talking about AI. Because AI is not actually interfering with a person's physical body, I think there is a perception that it is lower risk, and therefore we don't need to subject it to the same level of tests and scrutiny that we do almost every other type of medical intervention, whether that be a drug or whether it be a medical device. So I think we absolutely have to not fall foul of medical exceptionalism. And then the third thing is we need to let the system dictate the needs. So this was my point around information needs versus information wants. At the moment, we're assuming that we want more information all the time because what happens is, and what that drives is tech companies come in, they want a data set. Most of these tech companies just want to build a model. They don't necessarily want to build something for healthcare, they just know that healthcare has a lot of data. And then what happens is we have a tail wagging the dog problem. Whereas I think what we should be doing is going to the healthcare system, exactly like we've heard from Neil, exactly like we've heard from other examples. What are the pain points in your patient care journey where it would make a significant difference to your life and to your ability to take care of patients if you had a specific piece of information? And how do I get that piece of information to you faster, more effectively, more usefully, and in a more trustworthy fashion? So those are the three things I would say that you can do as leaders. And none of those things, importantly, none of those things require you to become a technical expert. I'm not saying that everybody in this room needs to come out knowing how to code in Python. That's a ridiculous thing. But those kind of things are high-level things. And then to the point with regards to how do we mitigate bias, first of all is acknowledge that it's there. So forget any time somebody says that AI is going to be more objective than a doctor. Say, no, it's not. It's going to be trained on records that are exactly, like you say, predominantly Caucasian Europeans, and they're predominantly men as well. Then we need to test and validate all of the algorithms against different population data sets. So we need to know where things break. So where does the bias happen? So don't pretend that it doesn't happen. Don't pretend that we can make a perfectly accurate algorithm. Test where it breaks, and then be transparent about where it breaks. Then we need to think about further up the pathway. So we need to get to the point where we are solving the problem at its source. Models are going to be biased. Models will always be biased. There will be no such thing as an unbiased model. But what we can do is make sure we know where the bias is and how to test for it. And what we can do is sort out the source. So, for example, there are 25% of NHS records are missing ethnicity records. That is a social problem more than a technical problem because people do not trust to disclose that to the NHS, and some people do not want to ask. So we have to think about the overarching point and go right back to the beginning of the pathway and think, how do we get this? Then there are some technical things about how we deal with fuzziness and missing and synthetic data, but those are the main things that I would say.
Goodness gracious me, I feel like there's a lot of work to do, but I heard curiosity. I heard leadership from us in terms of the questions we ask of companies that come in willing to sell us opportunity. I heard awareness as much as anything else, and I heard a real need for us to look at need, not want, as we move forward. There was another hand.
Thanks very much. I'm Dan Alton. I'm a GP. I'm Chief Clinical Information Officer of Bob ICB and National Clinical Advisor for Population Health Management at NHSE. And I'm one of those CCIOs that you mentioned that are being potentially sold things, big shiny things by tech bros, and I'm trying to kick the tires to work out whether this is smoke and mirrors or whether this is something that will make a real difference to patient care. And sometimes kicking the tires on AI, you discover that it's not actually a tire at all. It's not even AI. So that happens surprisingly often. But in terms of evaluation, it is sometimes lacking. Not just evaluation in terms of the simple evaluation, simple outputs of what we're getting, but real life, real world evaluation, qualitative evaluation. How is this deployed? And what were the success factors from a qualitative perspective as to what made it work or not, where it was deployed in real life. And really importantly, as Bola said, the inequalities element. Has this made inequalities worse? Has it made it better? What are they doing about it? So my question's about evaluation. From your perspective, I suppose Jess particularly, where are we with true evaluation of AI internationally, perhaps in other places where it's been done a little bit faster than here?
Okay, so internationally, it's actually not a huge amount better. The thing is that internationally, there are some places that have advantages because you can do it in a localized system. So, for example, if we take it in America, there are some slightly better things where they have done actual long-term evaluations of risk stratification tools, but that is because it's within a contained environment. They're not trying to do it at a national level, and also the incentive, to come back to the point we've had, the incentive structure is there, because if something is wrong, then they're not making enough profit. So they have an incentive to go and look. So I don't really think anybody is doing it massively well, and I think part of that is because there is not a legal requirement to do so, and so there's no kick. And we also shouldn't imagine that these things were perfect for other technologies, you know, like All Trials campaign, that was only 10 years ago. So we've got to be a bit realistic about that. So I think those where we are in the UK is very, very bad, because we don't even do it for basic risk strat tools. So we should.
So there are a couple of things. One, can I just share the anecdote of Amazon's recruitment strategy that ended up with a cohort of men for the very reasons that you've described, Bola. So when we talk about how we evaluate, there's something not just about the retrospective, there's something about how we build this prospectively. Second, I'm really minded by the conversation around kicking the tires and wondering if we're all kicking, if we're all going to have problems with our legs and cramps. Is there a system-wide approach, and at what level should we be all kicking the tires on this rather than individually?
Yeah, I just wonder if I could, on that note, and actually almost linking to the previous question, I think there's the various bits you can do from a technical evaluation part, but almost forgetting that, linked to this, but from a leadership perspective as well, is we need to start talking at several levels down from the level of every hospital will be using AI, yes. Finished. Yes. We need to be talking from whether that's a national or a hospital or a organisational perspective, what is your position on use of AI for this task? What is your use of position on LLMs or whatever it happens to be? Because actually we found that super helpful, because you get bombarded with companies, and actually the first thing can be, actually, what does your thing do? It's going to do this. That's not something we're interested in at the moment. And that solves, I know it sounds a bit simplistic, but if you haven't gone through that, you go, oh, that might be quite interesting. Yeah. Let's see what they say they can do. And then it becomes much harder to be clean and clear if you don't have that policy up front.
And I'm actually wondering about policy versus principle, because I think it takes time for the policy. Yeah, there's something about the fundamentals of principle. And I will share with you that in our organization, we're looking at radiology AI. And it is coming in, it is by stealth, it's probably in all our organizations. And my question is, if something goes wrong, have we got the right framework and infrastructure to deal with it, because we were proactive about it? So we put the brakes on until we understand. But it's that forethought. And in the space of quality improvement, small, PDSA, grow, is there an opportunity for us to be looking at this in a different way? Now, I've been really, really naughty because I know there was some online presence as well. Are there any questions that we need to be looking at from an online perspective? You're okay. Wonderful. Thank you. So just as we wrap up the session then, and I'm going to wrap up with positivity. Yes? So we're leaving this room with each of us a task to deliver. Some of that sits with you as leaders on an international scale. Some of that sits with us. I heard something around data. I heard something around EPR as a mechanism for that data and digitalizing. Is it reasonable to think beyond radiology and screening, where else we might think about AI in health and care? Because I think a lot of our conversation has really been about health. You all look at me. Simon, you've been quiet for a little while.
Oh, that's an easy question. I'm very taken with the sort of just preparing the way idea. There's, a lot of what both of you have said seems to me to about just, it's almost just like getting your ingredients out before you start cooking. And I think, the short amount of time I spent in the sort of domiciliary care, independent living technology world taught me that, we don't really take a kind of a holistic view of that. We just think, let's drop some tech in from 40,000 feet. So I'm quite interested in how we can think about this at a broader system level. And to the health economist out there, I do think there's something really, really important about having more kind of economic kind of input into this, right? So that and we can start to maybe think a little bit differently to the challenge that you quite rightly threw up, which is, if I invest in this but somebody else gets the benefit, well, what's the incentive for me to invest in it? So I think we're going to have to need to have a really kind of close look at incentive structures here to figure that out. So I think there's some sort of boring kind of boiler room work that needs to be done, as well as some of the more interesting, exciting stuff.
I'm really intrigued by the way you have investment and benefit in different spaces, and if that's a conversation for ICBs and ICSs, actually, is that the right footprint for us to start thinking that through?
Well, I mean, that's typified by sort of social and healthcare sectors,
Absolutely.
right? So that's a sort of would be one place to maybe focus.
Start the conversation. Yeah. Indeed. Neil, Jess, final words from you, particularly focused on care as well as health.
I think for me, the most useful thing is for whichever your organisation is, there are kind of, if you like, buckets of AI functionality, forgetting the particular company or whatever it is. If that thing could do the thing what you wanted, what's your list? Have you gone through your own organisation to say, wow, if we could only do this, or we could massively speed up our, I don't know, radiology, or if it's in a care setting, to say if we could massively do this with our documents, that would be the one thing. Because actually even just going through that process is quite helpful then in terms of planning the feasibility and what you might need to do as your first few steps.
And just to remind myself, actually, as I go back to my own organisation, we spend a lot of time talking clinically, but when you spoke about unstructured data, that really lends itself to non-clinical spaces, and I really want to not forget those spaces. Jess?
Yeah, so let me just first of all say that I do believe this stuff can work. The reason I spend a lot of my time thinking about all of the ways in which it can go wrong is so that we can prevent it going wrong and enable it to go right, just in case you think I'm like a giant killjoy. In terms of where I think we can do things better and use it for care as well, is following the entire patient pathway from when the patient transitions from being a patient to transitions being back to being a citizen and being back in person who's dealing with care. So we tend to think about patient pathways as being stopping and when you're inside the healthcare system and not necessarily those transition points. So for a classic example is that, and your point about unstructured data is exactly right. There are more than 13 different ways in which we record that a person is in a care home. There are better ways we can do that to manage patient flow. And so I think it's about focusing on where we can use AI to do things that we do currently really badly, which tends to be big macro system level views of things where people are moving in and out, where are the pinch points, where can we alleviate them, where is contract management not working, where could we make something better. That is something humans do not have the mental capacity to do, but an algorithm can. So I think we should focus our attention on that, and that is how we would bring the care system into the conversation.
Thank you. So I'm really hearing that need for focus. And Kevin, to your point, focus on where we want to do this and where we feel that there will be benefits, and away from areas where there might be other agendas pushing in a different direction. With that, I'm going to bring us to a close, and I'm going to say thank you very, very much to Jess, to Simon, to Neil, and to all of you for an interesting and fascinating session on AI. I still feel there's hope, but what I'm hearing is that it needs to be carefully considered and intentionally done. Thanks for your time. I think we've got tea and coffee, and then the amazing Chris Whitty this afternoon.